obstetric series. My name is Nidhi, and today we're going to be talking about the obstetric emergencies. So the people who weren't here before, my name is Nidhi and I'm a Trust F1 at Dorset County Hospital in the south of the UK. I graduated from Semmelweis University in Budapest in last June, and I did a thesis with the Public Health Department. I also did 1.5 years of research with the Institute of Enzymology in Budapest, and at the moment I'm doing a master's in public health with King's College in London. And in the future, I'm interested in doing humanitarian work, possibly with MSF. So today we're going to be talking about pre-eclampsia, cord prolapse, uterine rupture, placental abruption, placenta previa, and shoulder dystocia. It's quite a lot to get through here, but it's going to be quite interesting. So before we go on about all of that, we need to talk about resuscitation. So it's about obstetric emergencies today. So first of all, we need to go through a full A to E assessment. So if we talk about, first of all, we need to check the airways are clear. So we need to go to the patient and introduce ourselves and to see whether the patient is able to respond to us, and that way the airway is clear. If it's not, then we need to secure a clear airway. With breathing as well, we need to check the breathing. We need to see what kind of breathing it is, whether it's shallow or very deep breathing, whether it's very fast or slow. We need to see if there's any accessory muscle involvement there, if there are any breath sounds, what does it sound like on auscultation. We need to talk about all of that. Next, we need to talk about circulation. So we need to see whether there is a heartbeat or a pulse. Is it palpable? Is it regular? What kind of pulse is it? Is it fast or slow? We need to check the blood pressure as well and try to manage the blood pressure there. We need to check for signs of cyanosis, whether the fingers, the peripheries are blue. We need to see whether the circulation is well perfused. Next of all, moving on to D, we need to see whether the patient's able to move. Are they all able to move normally? Can they speak? Can they communicate? We need to see if they're confused. What is the Glasgow Coma scale on this patient? Are the pupils reactive to light? We need to check the blood sugars as well, whether they're hypo or hyperglycemic. We need to then move on to E with exposure. We need to see whether there's any wounds, any bleeding, any edema, discolorations, things like that. Okay. So first of all, we'll go on to pre-eclampsia. So pre-eclampsia is a new high blood pressure in pregnancy that has end organ dysfunction with proteinuria, which is protein in the urine. And so it occurs after 20 weeks. And this happens because the spiral arteries within the placenta form abnormally. So there's really high resistance in those arteries. And so it's a really, it's a high cause of maternal and fetal morbidity and mortality. And without treatment, it can lead to end organ damage, fetal growth restriction, seizures, early labor, and it can cause death as well. So preeclampsia has a triad of hypertension, proteinuria, and edema. So when we talk about hypertension, we need to differentiate between the different types of hypertension as well. So chronic hypertension is before 20 weeks of gestation, and it's long-standing. It's not caused by dysfunction in the placenta, and so it's not classed as preeclampsia. So pregnancy-induced hypertension after 20 weeks is quite normal. You can kind of expect that with any pregnant woman because they don't have proteinuria, so you don't need to be worried about that. So preeclampsia, like what we said, is a pregnancy-induced hypertension after 20 weeks, and it's got end organ damage and proteinuria. And so this can lead to eclampsia, which is the same as preeclampsia, but we've got seizures as well. We'll talk about that in a little bit more detail later on. So when you talk about your differential diagnosis here, so hypertension is blood pressure of above 140 systolic or 90 diastolic. And with proteinuria, it's above 300 milligrams of protein in a 24-hour urine collection. So you need to catheterize this patient to be able to figure that out. And so you've got a urine protein creatinine ratio of above 30, and you've got 2 readings of at least 2 positive protein on a dipstick analysis. So when we talk about maternal organ dysfunction, this involves the liver, involves the kidneys, and there's also hematological complications and neurological involvement. So can you guys tell me what kind of tests we need to do to figure out whether any of these will actually be involved? What can we do when we are suspecting preeclampsia? Can you guys just type it in the chat box? Yep, LFTs. Anything else? Yep. Yeah, really good. So FBCs, Usenes, LFTs, clotting, and you need to do a full neuroexamination as well. So yeah, because of the ureteroplacental dysfunction, you can also see intrauterine growth restriction and potentially a stillbirth. So these are the risk factors of preeclampsia. Some of the high risk factors are like chronic hypertension, if you've got hypertensive disease in a previous pregnancy, if the mother's got diabetes, any chronic kidney diseases or any autoimmune diseases. Any moderate risk factors is like a slightly older mother, whether the mother is the first pregnancy of the mother, whether there's been a long interval of above 10 years between this pregnancy and the previous one, if there's multiple pregnancies, so twins or triplets, and if there's pre-pregnancy obesity as well. So a BMI of above 35. And also if there's a family history of preeclampsia. So the clinical features, when you take a history, they will present with a headache, visual disturbances, swelling of the arms and legs and face, so the edema, nausea and vomiting, abdominal pain, and reduced urine output. On examination, you can find hypertension, as we discussed before, edema, epigastric and right upper quadrant tenderness because of the liver dysfunction, hyperreflexia and clonus, and also papilledema. So remember to check the backs of the eyes. And yeah, like what you guys said, we need to check FBCs, Usenes, LFTs, and clotting. And so for management, we need to monitor the patient's health and also the fetal monitoring as well. So we need to regularly monitor the blood pressure. We need to check for proteinuria and also regular blood tests. With the fetal monitoring, you have to look at the cardiotography, ultrasound, umbilical artery Doppler. And so depending on how severe the preeclampsia is, you don't need to do the last two very regularly. So if it's very mild, you don't need to do an ultrasound and a Doppler every couple of weeks. But if it's very severe, then obviously you do need to do that. So you need to use your clinical judgment a little bit there. And so with the management here, you can use aspirin because that can delay or prevent the onset of preeclampsia. You can use some antihypertensives to reduce, the aim is to reduce it to 135/85, and that should be continued up to 12 weeks postpartum. So you can use labetalol, nifedipine, and methyl-dopa for that. You don't tend to use ACE inhibitors or ARBs and thiazide because they're not very good for pregnancy. And you also need to have some VT prophylaxis as well. So low molecular weight heparin, as well as TED stockings, like the compression stockings. If there's severe preeclampsia, so we're talking about above 160 systolic or 110 diastolic, then this needs a hospital admission. And so there are lots of risk scores here, so the PIERS and the PrEP-S. So you need to use some of those to figure out what the risk is for any complications. And both of them take into consideration the gestational age and the clinical findings. And so you might want to consider early delivery, depending on the risk factors, so the risk scores, what they say, and also the gestational age, as well as the severity of it, the speed of progression. If you're not able to control the blood pressure with the antihypertensives, there's any complications, and also there's a compromise to the fetal well-being. And so these are the complications. So we mentioned about eclampsia before. So this is basically the same as preeclampsia, but with seizures. So it can be within 10 days of delivery, as well as hypertension, proteinuria, thrombocytopenia, and a raised AST. And so this has got quite a high mortality rate. So it's 1 in 50 women. And so the treatment of this would be intravenous magnesium sulfate to treat the seizures. Okay, and also we need to give some corticosteroids because the baby will most likely be premature. So can anyone tell me why we need corticosteroids if the baby's premature? Yeah, exactly. So it's to develop the surfactant in the lungs of the baby. Yeah, really good. So another complication of this is HELP syndrome. And so HELP syndrome is an acronym of hemolysis, elevated liver enzymes, and low platelets. So you need to get a blood film from any patient who you suspect HELP syndrome, and they're going to reveal schistocytes. And so this one is, you need to spot this quite early on. And so you need to give them magnesium sulfate, antihypertensive, and any blood products that they might need. And so if you do this quickly, then it's going to reduce the disease progression. Okay, cord prolapse. So this is basically when the umbilical cord goes below the fetal presenting part. It goes through the cervix, and it usually happens because of ruptured membranes. So this is a really fatal obstetric emergency, and it can lead to fetal hypoxia if you don't spot it and treat it quickly. So normally this is because of the fetal malposition, as well as like other obstetric procedures. So if you have a breech lie or a transverse or maybe even unstable lie, this can cause it. If you've got twin pregnancies or multiple pregnancies, that can cause it as well. And also artificial rupture of membranes and external cephalic version. So these are the clinical features. So when you take a history, it's usually with the rupture of the membranes that should set off alarm bells there for you, and also any potential risk factors that might cause this. And on clinical examination, so we can palpate it on the vaginal examination. And also you've got acute bradycardia or fetal distress. So it's below 100 beats per minute on the CTG. So that can be something. And also very rarely you can actually see the umbilical cord hanging out as well. So the investigation, I mean, it's basically just on clinical findings. You don't really need to do any blood tests or anything for this. And you can also use an ultrasound just to assess the fetal position to see whether that's actually going on there. So like we said, this is an obstetric emergency, and it can cause vasospasm and fetal hypoxia if it's untreated. So you can do a vaginal examination, but you need to take care to avoid touching the cord, as this can actually cause vasospasm and make things much worse. You can fill the bladder as well, because that will help with the elevation of the fetal presenting part. And so how would you go about filling the bladder up? If you wanted to fill up the bladder, Yeah, a catheter. You can also ask them to drink water, I guess. Yeah, so you put a catheter in and you can inject some fluid in there to fill up the catheter quite quickly. Yeah, and also the maternal position can reduce the pressure on the umbilical cord. So you do the knee chest position. So it's quite similar to rolling the woman on all fours, but the pelvis is higher than the shoulders. And yeah, you would need to do an immediate C-section. If the fetal heart rate is abnormal, then it's category 1, which means that the delivery needs to be within 30 minutes. So it's pretty urgent. And so, like we said, we can cause birth hypoxia for this. And so you need the neonatology team, the pediatricians and the ICU people there at delivery. And we need to take the umbilical cord gases and to assess the fetal pH to see whether the baby is going to be hypoxic or not, and treat them accordingly. And also can cause psychological trauma for the parents as well. So the mother should be aware of what happened, and everything should be explained to her and the father, to like ease the emotional trauma a little bit as well, because it's quite a traumatic event. All right, uterine rupture. So this is a complication of labor where the muscle layers ruptures. It's fairly self-explanatory there. You can have different levels of rupture as well. So incomplete dehiscence or the whole serosa. And so the complete rupture is when the serosa ruptures along with the myometrium and the contents of the uterus are released in the peritoneal cavity. So this can cause a lot of bleeding, and the baby might also be released from the uterus into the peritoneal cavity, and it can, yeah, it's really fatal for both the mother and the baby. So the main risk factor for this is a previous C-section, but you can have other risk factors as well. So like a vaginal birth after cesarean, previous uterine surgery, increased BMI for the mother, if the mother's had lots of children in the past, an increased age, and also induction of labor can cause this as well. So the use of oxytocin to stimulate the contractions, which can be used in the induction of labor, can also cause this. So normally it presents with a very unwell mother with a really abnormal CTG. And so it can occur with the induction or augmentation of labor. So a lot of abdominal pain, lots of bleeding, ceasing of the uterine contractions, hypotension, tachycardia, collapse. It's all very serious, and this is when we need to resuscitate the mother. Yeah, so it's an obstetric emergency. And so we need to do the full A to E assessment that we talked about at the very beginning. And a transfusion might be required here. And yeah, an emergency C-section is necessary to remove it and also stop the bleeding. And they need to be aware that a hysterectomy might be necessary for this. Moving on to placental abruption. So this is a separation of the placenta from the uterus, and that can cause hemorrhage into the space in between. So it occurs between 0.3 to 1% of births. So depending on where the uterus is and where it's separated, it can cause different types of bleeding. So if it's at the cervical os, then it can cause external bleeding. If it's at the top of the uterus, it can cause internal bleeding. There are quite a few risk factors here, like pre-eclampsia, any complications, advanced maternal age, like most of these cases, multiparity, same as that. So a low body mass index can actually cause this, as opposed to the other ones, which is a high body mass index. Pregnancy following assisted reproductive techniques, so IVF, for example, any kind of intrauterine infections, which can be caused by premature rupture of membranes, any kind of abdominal trauma, and any smoking or drug misuse during pregnancy can also cause this. So about the clinical features, when you take a history, normally there's sudden constant pain, and it can be with or without dark vaginal bleeding. Obviously, it depends on where the placenta is, like we spoke about before. And so when you take a history, you need to ask about any other rupture of membranes, any provoking factors that might have caused it, like postcoital, because that can cause a rupture of membranes. You need to ask about fetal movements, whether they're normal, increased or decreased, any risk factors like smoking or drug use during pregnancy, and you need to take the obstetric history as well, which I spoke about before, past medical history, and about IVF. And when you do the clinical examination, you don't do a digital examination because that can cause a lot of heavy bleeding in a placenta previa which is not confirmed. So instead you can do a speculum examination, and on that you will find, either way you'll find abdominal tenderness. The uterus is very hard and woody and very tense. You can also get signs of shock as well, and a CTG at 26 weeks of gestation or above. If not, then you can just auscultate the fetal heart. So the bedside investigations, you can do CTG like we spoke about. So the lab investigations, just normal FBCs, Usinese, LFTs, group and save and cross-match in case you need to transfuse the lady, clotting, and a Kleihauser test. And so that's if the woman is rhesus negative. And also an ultrasound to see where the placenta is and like the status on the integrity of the placenta, whether it's separated or the degree of separation as well. And yeah, just the same as all the rest of these, you need to do an ABCDE assessment and resuscitation. And it depends on the gestation and the presence of fetal distress. So if there is fetal distress, then emergency C-section straight away. There's no fetal distress and it's below 36 weeks. You can just observe and give some steroids. You don't go give like tocolysis or anything like that. If there's no fetal distress and it's above 36 weeks, you can induce labor and deliver vaginally. If there is fetal death, you can induce vaginal delivery or you can do a C-section. And you need to give anti-D for anyone who's rhesus negative. And yeah, the maternal complications of this can be postpartum hemorrhage, clotting problems, organ dysfunction because of the hemorrhage. And the fetal complications can be the intrauterine growth restriction, hypoxia, stillbirth, premature birth as well. And so this is associated with quite a high mortality rate, and it's responsible for around 15% of deaths, which is quite a lot. Moving on to placenta previa, speeding through them today. So there's lots of different grades of placenta previa. It can be minor, where it's a low-lying placenta, but it doesn't actually cover the internal os of the cervix. Or it can be a complete placenta previa, where it just completely covers the internal os. So looking at this is the normal location of the placenta, and this is the placenta previa. Obviously, like we said before, it can be a different grade, but generally it's just when it's covering the cervix, and that prevents a normal birth. And yeah, the risk factors of this would be a previous history of a placenta previa, any previous C-sections. So actually this is quite a major risk factor of this, increasing maternal age, lots of children in the past, smoking, drug use. If there was any abortions in the past, this can also be a risk factor, and endometriosis, and also assisted conceptions, IVF again. So taking a history of placenta previa, so you might ask about hemorrhage, any kind of bleeding. You might have some light contractions there. And you also need to ask about fetal movements and obstetric history, just the same as everything else. any past medical history like endometriosis, because that's a risk factor, and any provoking factors as well. So with the examination, you don't do a digital vaginal examination because that can cause heavy bleeding again, but you can do a very careful speculum examination. And so you'll find a non-tender uterus this time, which is different to placental abruption. You get vaginal bleeding, and you might have signs of shock as well. So yeah, you can do CTG above 26 weeks. FBCs, you need LFTs to rule out other conditions, group and Sabin cross match in case of transfusion, clotting, Kleihauser test again. And so with ultrasound, that's where you get a definitive diagnosis of placenta previa. And you can also do a transvaginal ultrasound because it's considered to be quite safe. With the management of asymptomatic placenta previa, at the 20-week scan, if you see that there is a placenta previa, it can be rescanned at 32 or 36 weeks, depending if it's major or minor. And then if it's still present, you can do serial scans every 2 weeks just to see how it's going. And then you can do a final ultrasound at 36 or 37 weeks to determine what method of delivery you're going to go for. So if it's a major placenta previa, you might do an elective C-section. If it's quite minor, then you can try to do a vaginal delivery, but that's if the placenta is at least 2 centimeters away from the internal os. And yeah, they just need to be aware that placenta previa carries an increased risk of obstetric hemorrhage, and they might need a hysterectomy because of this. And so if you do have bleeding, if you have antepartum hemorrhage, then again, just the same as everything else, you do ABCDE assessment, and you might need an emergency C-section. So the complications of this, the maternal side, hemorrhage, hypovolemic shock because of the hemorrhage, and that might lead to death as well. And the fetal complications, you can get fetal hemorrhage, intrauterine growth restrictions, and premature birth. So moving on to shoulder dystocia. This is basically when the anterior fetal shoulder becomes stuck on the maternal pubic symphysis. And so that it delays the birth of the baby's body, but the head has been delivered. And so this is really, really urgent because there's a risk of hypoxic brain injury for the patient, for the baby. Yeah, so like we said, it's because of the baby's head is delivered, but the shoulders are not going forward. And so this can cause the umbilical cord to be compressed between the baby's body and the mother's pelvis, or the baby's neck might also be compressed. So that's how it causes hypoxic brain injury. And so the longer the baby is trapped, the greater the risk of hypoxia is. So this needs to be sorted out immediately. This is really, really urgent. So the risk factors of this is a previous shoulder dystocia, very large baby, if the mother's got diabetes, if the mother has a body mass index of above 30, and also if there's an induction of labor, then this can also cause shoulder dystocia. And intrapartum risks is a very long first stage of labor. If there's a secondary arrest, or if there's a very, very long second stage of labor as well. There's oxytocin augmentation, this can also cause it. If there's an assisted vaginal delivery, and also macrosomia, the same as the pre-labor risk factors, and diabetes as well. So yeah, you don't really need to take a obstetric history with this because you can see it right there. It's an emergency, so you don't really have time to take a history. You need to act immediately. And with the clinical examination, you've got a very slow delivery of the head, and you're not able to deliver the anterior shoulder with the next contraction. And also there's a thing called a turtleneck sign, where basically the baby's head is like a turtle going back into its shell. It's like kind of goes back in, and it's got a very red puffy face as well. And so with the investigations, like I said, this is a very time critical obstetric emergency, so you don't really have time to do kind of bloods or anything like that. And so you just go for a full ATE immediately. You see if there's any shock or hemorrhage, so that needs to be addressed. And well, you can do these ones, but before you don't really have time to take bloods. So the initial management, you need to call for help. So you need to call your consultant, you need to call a senior midwife, and the pediatrician has to be there as well because of the risk of hypoxia. You have to advise the mother to stop pushing because that can worsen the fetal impact. Sorry, I just got a question. Is the red puffy face in shoulder dystocia due to superior vena cava obstruction? It's the puffy face of the baby. Sorry, I should have specified that before. Because of the hypoxia, it's like very red and puffy. Okay. So the McRoberts maneuver, this is basically when you flex the hip inwards of the mother. So you push the leg inwards, and then you push down on the pubic symphysis to allow the baby's head and shoulders to kind of move through a bit more easily. And so if that doesn't work, you can do an episiotomy, and that's not really going to relieve the, it's not really going to solve the problem, but it can help you kind of maneuver things a little bit easier. So you can, when you do the episiotomy, then you can put your hand in and try to deliver the posterior arm and deliver the whole baby out at the same time. Or you can do an internal rotation, which is called a corkscrew or Rubens maneuver, where you basically move both of the shoulders around and then deliver the baby by internally rotating it. And so when you do this, you have to avoid downward traction on the fetal head, as it increases the risk of brachial plexus injury. And do you know what it's called if you have brachial plexus injury? What is the sign that the baby can have? Yeah. Yeah, so Erb's palsy, waiter's tip, or policeman's tip, it's kind of the same thing. So it's when it's kind of back like this and the hand is flexed like this, the top. Good. So case studies. Right. So case number 1, you are asked to review a nulliparous woman who is presented with vaginal bleeding at 39 weeks. So at the GP, the blood pressure was 123/72. But this evening, she noticed a small gush of blood and a bright red stain in her underwear. She doesn't have any abdominal pain, but there's some intermittent lower abdominal discomfort. The baby has been moving normally throughout the day. So what do we think about the blood pressure here? Yeah, it's absolutely fine. So on examination, you see that she is warm and quite well perfused. Her blood pressure now, when you take it, is 158/87. Heart rate is 84. You see some moderate uterine tenderness. Uterus is soft on palpation. There's 2 moderate uterine tightenings when you palpate it. On the speculum, you see that the cervical os is closed and there's a moderate amount of vaginal blood. So what are we thinking? What do we think it might be? I'll move back. Okay, so here we're thinking about placental abruption. Okay, because of the uterine tightenings. And it's quite soft during palpation. And she's got a little bit of hypertension here. There's like a moderate amount of vaginal blood. The cervical os is closed. So for this, you're going to admit her for observation. Okay, what else would you do if you're thinking about placental abruption? Yeah. Yeah, I mean, we don't really need an A to E at this point because it's not super critical. You can see that she's not like very, very unwell. She's just got a bit of tenderness, but it's not painful in itself. But yes, we need to admit her for observation. We need to get some IV access immediately. We need to do group and save. So you guys are absolutely right with that. FBCs, all of that. And you need to also repeat the blood pressure at regular intervals as well, because if you see on the previous one, we can see that it's slightly raised. So we need to monitor that. And if it's necessary, we might need to start on antihypertensives. So what kind of antihypertensives can we use in pregnancy? Yeah, labetalol. Sweet. Very good. And you might need to induce labor to reduce a risk of like a sudden and catastrophic hemorrhage. So you might want to have it in a very controlled way rather than just waiting for labor to happen. You might want to induce it. Okay. Yeah, you might need to, yeah, that's a good question. If a patient has asthma, can we still use labetalol? Yeah, that's a good point. There are other antihypertensives to use if the patient does have asthma. Can you think about the other ones? Methyl dopa, yeah. One more. It's one thing that I just mentioned before. Can anyone remember? Nifedipine, yeah, awesome. Very good. Case number 2, last one. So you're urgently called to the delivery room of a 26-year-old woman to help deliver the baby. Mother is at 41 weeks into her second pregnancy, having a normal term delivery of a 3.97 kilogram female infant 2 years ago. So the nuchal anomaly scans were normal and the antenatal care was absolutely fine. The baby was moving normally before labor. So at the beginning, the cervix was dilated to 3 centimeters, and so she was advised to move around a little bit. And so there was a spontaneous rupture of the membranes, and she was examined again after 4 hours, and the cervix was still 3 centimeters. Not moving along very fast, are we? So then an infusion was commenced to start the labor, an epidural site with CTG monitoring. After another 4 hours, the cervix was 7 centimeters, and then 10 centimeters after a further 4 hours. So it's taken a very long time. And then the woman was encouraged to start active pushing, and then 35 minutes later, it's quite a long time, the head had crowned into an occipital anterior position, which is normal. Then the midwife noticed that the head didn't really extend normally on the perineum, and the chin appeared to be wedged against the perineum. So she had tried to deliver the shoulders with the next 2 contractions, but it didn't really work very well. So what are we thinking here? Yeah. Awesome. You guys got it immediately. Great. Shoulder dystocia. Yeah. What should we do? Yeah, some really good ideas. Any more? Yeah. Awesome. Really good. So, first of all, yeah, awesome. So, first of all, you call for help. Yes, you call your senior, you call your consultant or the senior midwife immediately. You consider an episiotomy to help to the manipulation of trying to do this. You try to deliver the posterior shoulder with you put your hand in and try to pull the shoulder out with everything else. And you can try the McRoberts maneuver, like you guys said. So pull the leg in and push the pubic symphysis down and try to deliver that way. You can also do the Rubens maneuver, which is the corkscrew. So try to rotate the shoulders of the baby and try to get it out like that. Really, really good. And you can also roll the woman onto all fours because that increases the sagittal measurement of the pelvic outlet by 20 millimeters. So that's quite a significant amount, and that might help to deliver the baby as well. And so if none of this works, then for a very last resort, what can you think about doing? So how would you do a C-section when the baby is like half out? So you guys were right when you said the C-section, but you have to replace the fetal head back into the pelvis and do a C-section like that. And yeah, how someone else said you can do a symphysiotomy. It's a very last resort as well. Awesome. You guys were